Support for UWTV is provided by the Boeing Employees Credit Union.
Hello and welcome to Talk Medicine. My name is Nelson Hager and I'm a musculoskeletal and sports medicine specialist who works at the University of Washington. My training is in physical medicine and rehabilitation. And today I'm going to talk to you about a patient encounter I had with a patient of mine named Erin Aas. I had the privilege of taking care of Erin. You'll meet him here today. He's a high-end triathlete, also happens to be a healthcare practitioner himself. I first saw Erin about 6 months ago when he presented with a knee pain that wasn't getting better, especially when he tried to conduct his sports or train for his sports. So I'd like you to meet Erin, who is here today to talk about our encounter. Let me kind of take you back to our initial encounter and ask you if you could recall where you were at that point in time and what sort of problems you had, maybe what you were involved with that led you up to that problem.
Sure. Well, I came to you in October, or actually I came to you in January, and I had been dealing with a knee injury that had begun in October, about 2-3 months earlier. And at that point I had been training for an Ironman triathlon, and so in October I was starting to increase my mileage running and biking, and I started to have some issues with my right knee. I'd had some pre-existing knee issues from an injury in the past there, but this felt a little bit different. So I had essentially stopped any kind of training in November. I'd seen actually 2 orthopedists outside of the university. I'd had an MRI done, and I was getting increasingly frustrated because while I did know that I was injured, I didn't feel that anyone was able to offer me any helpful suggestions as to what to do in addition to just laying off of it. And I didn't have also a way to follow the injury so that I actually knew that healing was occurring. So I was referred to you by a friend who's a physician and also a colleague of yours at the university, and so we first met in January.
Fair enough. And as you think back, what were your primary concerns on that first visit? What was bothering you the most?
Mm-hmm. It was fairly painful, although the pain was something that I could deal with. It was really wanting to find out how and when to get back to being athletic and getting back into training. And up to that point, it had just been getting worse and worse, even though I had been probably 2 months without doing anything much on top of walking. And so I really wanted to be able to have a more structured rehabilitation plan, and I think that led me to want to see someone who had a better understanding of some non-surgical options for following something like this.
I can tell you what I recall about that first encounter. It became clear to me very quickly that your training and your exercise activity was critical to your life, to your quality of life, and very important to you. And you weren't getting the kind of answers you needed.
Right.
So.
And that was absolutely the most important thing, and it essentially derailed everything I'd been doing, and I was no longer doing yoga or running or biking or even swimming at that point. I was just essentially walking back and forth between my home and my car, which was it was a pretty different lifestyle, and so I really planned to get back to it.
And having sports and activities an important part of my life, I was tuned into that for you. Let me share with you, if I will, briefly what I recall about what was available to us from the standpoint of what had been done diagnostically up to that point. You had an MRI of your knee, we have a history that showed that you had a previous surgery in that same knee. And if I remember correctly, it was almost 3 years worth of pain off and on with certain activities.
Right, that's right. And it was, we felt that there had been a meniscus tear in the knee a few years earlier, but I did have arthroscopic surgery about a year prior to coming to you, and there wasn't anything that was fixable in there, but I did get back to activity after that and did several triathlons that summer. But again, so there had been a course of some kind of strange injuries, and so there may have been something that had really impaired my mechanics in the way that I was biking or running that set me up for another injury.
And if you, as you think back, of the 3 activities, you're a triathlete, and a good one, of the 3 activities that were bothering you the most, which seemed to cause the most pain for you?
I think it may have been the biking. It's hard to say because it did hurt much of the time, but I had just recently that summer got a second bike, a triathlon bike that has you in a much different angle than a normal road bike would. So there was possibly something in that that had set me up. But again, I think the important thing was I didn't really know where this came from, and that was where a lot of my frustration lay, and that's why I was so eager to come see you, as you yourself an athlete, you as someone who I felt like was going to have a larger palette of tools to deal with.
And let me add too that you had seen some good orthopedic surgeons, and this did not appear to be a surgical problem.
That's right.
Which is essentially what we deal with, and
Right.
try and look harder at that. But going through the details of how you present it also makes me and you aware of how complex all of the contributing factors are. So let's sort through what we did based on what was presented to us. And one important fact in what we were looking at is the MRI did show as a finding that you potentially had a tear in one of your hamstring's tendons. And there was swelling within the bone that that tendon attaches to. Do you recall that?
Yeah, I recall it very well.
You recall it well because you were feeling it.
Yeah.
And as part of the physical exam, and our physical exam, when you come to my sort of a provider, a physical medicine and rehab provider, includes both a functional exam, walking, observing your gait, if possible, even observing you doing your sporting activity, as well as a hands-on exam. And it did confirm that it looked like the most tender portion of your knee was at the attachment of that particular tendon. It didn't appear that the meniscus was involved based on the physical exam, and other structures did not appear to be focally tender.
Right. And that was something that I appreciated quite a bit as well, because I really wanted to get down to some of the nuances in this, that it wasn't just a knee injury. I really, whether it was realistic or not, I really wanted to know exactly what was, to the best of your knowledge, exactly what was going on there. And I appreciate it because I remember in the first visit we took about an hour and we really went through in more detail than even I was expecting, which was very reassuring to me at that time.
And it may seem that you have the answer there in front of you, so why isn't it easy to fix? And that takes us to part 2 of your treatment, essentially. And part of that has to do to treat any patient population, and almost especially high-end athletes that put more stressors on their body. It's critical to get a key and focused look at what you think the cause of the pain is. Erin, if you remember at your first appointment, we discussed all the options we had available to taking care of you. And part of what we need to sort through diagnostically is what tools needed to be used. In our clinic, as a musculoskeletal and sports medicine clinic, we have several tools at our disposal. I'm specialty trained in electrodiagnostic medicine. If we need to take a hard look at the nerves, we could do that using an EMG machine and or further analysis along those lines. We could use the musculoskeletal ultrasound to take a harder look at the soft tissue structures below the skin. And we have a pool of subspecialists that we can use at our disposal to provide and educate you on the use of orthotics and or assistive devices for your gait, etc. So in your case, however, what we ended up doing and using was musculoskeletal ultrasound, and that's a tool that allows you to take a harder look, or look under the surface of the skin, if you will. It's your musculoskeletal flashlight. And match the point of maximum tenderness with what's going on beneath it. We had the preliminary study of the MRI that already gave us a hint. And we thought not only could we dig deeper by looking at it on a follow-up visit, but also tracking it over time as you return to your sport, which I know is your primary goal.
Right.
So let's review some of the images that we took of you over time, and along the way talk about the capabilities of the machine. So if you recall, we can go back to the first image, and part of what we discovered with that first image was what the structure itself was looking like. And here is the primary tendon. It's brighter in this area, and it had around it these darker areas. Musculoskeletal ultrasound has a exquisite capability of showing you that level of detail around those structures. It also showed us where we suspected the tear might be, and identified where the bone structure was changed as part of your injury, where you maybe had a fleck of bone pulled away. That's the level of detail of ultrasound.
And you might point out one thing I found interesting was how it could actually tell us where there were areas where there was more blood flow, which could also indicate an injury there.
Right, and a Doppler is what you're alluding to. A Doppler is the brighter, you see the brighter areas within in and around the bone, and that Doppler shows flow, and the flow can be where there is new blood vessel formation and or moving blood flow in that area. And so it can be very helpful. The other very unique thing about it is it's real time, and we can look where your pain is. It can look beneath where you're pointing on your skin. Also, it collects dynamic images, meaning I can move it across the structure, and we can watch that structure in full length in both the long and short axis, as well as you can move the structure beneath it. So we can watch you move your knee. If you recall, we had you tense that tendon, that hamstring tendon, to see if it would pull away that tendon from the bone, and that would have happened right in this area. So some of the other images that you recall are different angles of how we looked at each of those structures, and those are all recorded for you here. And what's nice is we then have this library that we can refer to on subsequent visits. So let's talk about from the first encounter when we discovered what was going on there, some of the things that were considered in going after this.
Sure.
Beyond, I would say at this point we've got a pretty good handle on where the source is. And talk to me about some of the things that we use to get after this.
So what we decided to do initially, if you recall, that despite laying off of most activity, it was just getting worse no matter what I seemed to do. The simple act of walking really exacerbated it over and over again. And so we decided initially, just after the first visit, that it would be wise to go on crutches for a while. And of course, we didn't want to do that, if at all possible, but it was clear that we just needed to be a little bit more aggressive with it. And so at your office, a splint was fashioned that would keep my knee flexed a little bit so it wouldn't stretch my hamstring out. And I actually did go on crutches for a couple months. And that was when we started monitoring this over time. So I started coming into you periodically to repeat the ultrasound so I could see over time how healing was actually occurring. And again, it was very helpful because, as you said, we could perform the ultrasound on my healthy knee at the same time, and so I could see how the two of them differed. And over time, it was interesting to see how my bad knee started to look more similar to my healthy knee, and so that was pretty indicative of healing.
That's a good way to describe it. The other thing that occurred to me as you were talking, there are a couple points that I think are key in a healing athlete. When it's awfully hard to get them, it's the concept of relative rest. They are going to train no matter what. It's a matter of bridling that energy, if you will. And you, I give you credit because you cooperated significantly early on, and we needed to ratchet that rest up a little bit.
Right.
The other thing is we explore different options with braces and that sort of a thing. We have that capability at our institution of doing that. Some were more successful than others.
Right.
I appreciated the fact, I want to tell you this now, that I felt very much like it was a team exchange. And in these sort of encounters, it's often that way. It's a give and take. You give me feedback about what's working, and you were exceptional at that. And I try and modify as we move forward, and you help me with those decisions. It's not a matter of me dictating, this is what's going to work, come back and see me in 6 months.
That's right. And the first time we worked with the technician as well, who fashioned a splint initially that we all thought would work. And after a day on it, it really didn't do what we had intended. So I called on a Friday, and then the tech talked to me and actually brought me in at the end of the day and fashioned something so I could have something over the weekend. So I really felt that they were pretty responsive, and I appreciated that team element as well.
So as we move forward, as a triathlete, you cross-train, and we had identified early on possibly a setup, a biomechanical setup of this injury. And I feel like in our discussion we're now at the point of talking about, as it quieted down, as it healed, we had to think through trying to prevent this from either recurring or re-injuring.
Right.
Because your goal is, what is your goal?
So my goal is to, obviously the Ironman this summer is not happening. That's what got derailed. But my goal now is to bring that out a year. So it would be to train for an Ironman in 2010. So just over a year from now. And so for me, I think it was largely your prompting to try to figure out what was going wrong mechanically that led up to this, and how to correct those things so that it doesn't set me up for future injury or re-injury from this. And that was something that I wasn't overtly aware of, something that was wrong. So it was obviously something subtle in the way that I was biking or running. And so it was obviously, you were fairly adamant about trying to correct those things, and that's what we're working on right now.
And fair enough. Part of our initial functional exam, it picks up gross errors, but I often pull other resources to help me with the biomechanical evaluation of you when you're stressing it at speed. And with that, it means putting you on the vehicle that you're going to ride, and or putting you in your running shoes that you're going to wear, and taking you to a level that is going to demonstrate some of those. Now, our limitation early on is you're painful and we don't want to re-injure it, so we couldn't quite test it. So as we moved forward with this, we saw the opportunities from least stressful to more stressful to try and test if your biomechanics was perhaps affecting your
That's right.
your knee. And explain what we did with that.
So it's a couple steps. The first one was to go after the bike. So I slowly started getting back to cycling, and it was nothing strenuous, but I was at least able to get on my bike, to put my bike on my trainer in my living room, and to be able to spin without any sort of pain with that. And once I was able to do that for 20 minutes or so, I went to a physical therapist who does bike fits as well, on your recommendation. And so he got me on the bike, watched what was happening, and it actually adjusted a number of things. So my hope is that will prevent injury, and that remains to be seen how it will go out once I actually start increasing mileage biking. And then the second piece is doing a gait analysis to actually see if there's something in my running that is leading to this. And that's something that will happen in a few weeks. I just got back to some very, very light jogging and haven't had problems with that. So as I increase that, we'll try to figure out if there is something in how my feet are landing or in my overall mechanics that are also contributing to it.
And that's the one we're going to be particularly careful with, because
Right.
it tends to put more stress on your body over time.
Right, that's right.
It's been a privilege working with you on this, and as I recall back, an interesting thing about this entire treatment plan is medications were never a part of it.
Right.
We talked about, but never really had to do an intervention. There are interventions that you can do in and around a tendon that are out there. But really, it turned out in your case that it was modifications of activities.
Right.
It was tuning into what will allow your body to take care of itself, and then working as a team to make that happen and make
Right.
you heal.
And that was important to me because coming in with an injury that was causing a lot of pain, it was pain was not my concern. It was not I want to get to a pain-free place. It was activity, and I want to get to a highly functional place. And so that was something that I feel that you were able to offer that I wasn't getting prior to coming in.
And in fact, ironically, we use pain as part of your guide,
Right.
and along the way, and, and based on the level of pains, we needed to stay away from certain things.
Right.
Well, it's been a pleasure, and we'll stay a part of this team and continue to see each other as we need to over time, and you can help me decide how often that will be, and so hopefully you can reach your goals next summer.
Yes, and my pleasure as well. Thank you.
Thank you very much, Erin. And thank you all for joining us for another edition of Talk Medicine. My name is Nelson Hager. Good day.